All right, let's dive right in. Today, we are going on a really fascinating and, yeah, maybe a little wince-inducing anatomical tour of the shoulder. We're going to decode what exactly happens when this incredibly mobile joint gets damaged. I mean, maybe it's happened to you, or you know an athlete who's been sidelined by a bad shoulder injury. It is an incredibly common problem. And believe it or not, the answer often comes down to one small but absolutely vital piece of tissue. So, let's meet the hero of our story, the labrum. The best way to think of it is like a rubber gasket or maybe an O-ring. It's this ring of cartilage that sits right on the rim of your shoulder socket, and its main job is to keep the ball of your upper arm bone securely in that socket. So here's our roadmap. First, we'll cover the basic mechanics. Then, we're going to tour the labrum from the very top to the bottom, looking at common tears, what can mimic them, the kind of damage you see from a dislocation, and finally, we'll check out the ripple effects on nearby nerves. Okay, first up, let's really get our heads around the fundamental trade-off of the shoulder. This joint has the greatest range of motion in our entire body, right? But that incredible mobility, it comes at a price. And that price is a lack of built-in stability. And this is just a brilliant way to picture why. The shoulder socket, which is called the glenoid, is actually super shallow. It's much more like a golf tee than a deep cup. And the ball of your upper arm, the humeral head, is just kind of resting on top like a golf ball. So the labrum's job is to build up the edges of that tee, creating a deeper, much more stable cup for the ball to sit in. Without it, that golf ball will be falling off all the time. All right, let's start our tour at the 12 o'clock position of the labrum. This is the superior part, the very top of the socket. And it's a super common spot for a specific kind of injury called a slap tear. A slap tear happens right at the top, right where the long head of your biceps tendon actually anchors to the bone. And that's exactly why it's so common in athletes who do a lot of overhead stuff. Think swimmers, baseball pitchers. When a radiologist looks at an MRI, they're looking for a ragged, torn margin. That's the telltale sign of this injury. But here's where things get really tricky. Not every gap you see at the top of the labrum is actually an injury. Sometimes it's just a normal variation in someone's anatomy. These are called mimics, and they can look almost exactly like a real tear. It's a classic case of mistaken identity in radiology. So let's compare the real deal to its most common mimic, the sublabral recess. The absolute crucial difference is the margin. See, a tear is ragged and irregular, but the normal recess, it has a smooth, clean edge. The recess also tends to be smaller, and it follows the natural curve of the bone. A tear, on the other hand, can shoot backward where it just shouldn't be. And believe it or not, there are other mimics. A sublabral foramen is just a normal little gap where the labrum isn't attached to the front. And the Buford Complex is even wilder. The labrum in that same area is completely missing, but a nearby ligament is extra thick to make up for it. And that Buford Complex, it's not some crazy rare thing. It's in about 1% of the population. So literally 1 out of every 100 people walking around is just built that way. It's a fantastic reminder that in anatomy, normal has a pretty wide range. Okay, our tour now takes us down to the front and bottom half of the labrum, from about the 1 o'clock to the 6 o'clock position. This is the zone that gets hit really hard during a typical forward shoulder dislocation, and it leads to a whole alphabet soup of related injuries. Instead of trying to memorize a bunch of names, it's way easier to think of these injuries as a spectrum, a progression of escalating damage. We start with something called a glad lesion, which is pretty mild, and we go all the way up to a true Bankart lesion, which is a much, much more significant and destabilizing injury. And this table just lays out the differences beautifully. A glad lesion, it's just a superficial tear, no real instability. But once you get to Perthes, ALPSA, and Bankart lesions, the labrum is actually detached, and that's what causes the instability. The real key differentiator here is the periosteum, that thin lining over the bone. In Perthes and ALPSA, it gets stripped away, but it's still intact. In a true Bankart lesion, it's totally disrupted and torn. For a surgeon, that is a huge distinction. Now for a fun twist. We all know anterior or forward dislocations are way more common, but you can also dislocate your shoulder backward. And when that happens, a lot of the same injuries can happen just in reverse. So, welcome to the bizarro world of posterior injuries. You've got a reverse Bankart, a Pielpasa, which is just a posterior L-pasa, and other specific ones like Kim's and Bennett lesions. The principle is exactly the same, it's just mirrored on the back of the socket instead of the front. And, you know, it's not always the labrum that gives way. Sometimes The force of a dislocation is so intense that one of the main ligaments holding the shoulder together gets ripped right off the arm bone, the humerus. That's called a Hagel lesion, and it's another major cause of instability. Okay, for the final stop on our tour, let's zoom out a little bit. Damage inside the shoulder joint doesn't always stay inside the joint. All that inflammation and fluid can create cysts that start pressing on nearby nerves, causing this whole ripple effect of problems. Now, this is a fantastic high-yield rule to just lock into your brain. If a cyst forms up high in a spot called the suprascapular notch, it pinches the nerve before it splits into two branches, so it affects two key rotator cuff muscles. But if the cyst is a little further down in the spinal glenoid notch, it pinches the nerve after it splits, so it only affects one of those muscles. The location of the pinch tells you everything. And here's another classic example, Quadrilateral Space Syndrome. In this case, the axillary nerve gets squeezed in this tight little anatomical box, bordered by 4 different structures. And the result? Weakness and wasting away, or atrophy, in one very specific muscle, the teres minor. It's just a perfect example of how interconnected all this anatomy really is. And that really brings us full circle, back to the central theme of this whole explainer. The very thing that makes the shoulder so amazing, its ability to move in pretty much any direction, is the exact same thing that makes it so vulnerable to getting hurt. It's a true engineering marvel built on a fundamental trade-off. You know, understanding all these intricate failure points isn't just some academic exercise. It is the key to diagnosis, to treatment, and most importantly, to prevention. Which really leaves us with the big question, right? How do we best support and protect this incredible joint so we can use its strength without falling victim to its weakness?